Again, my name is Kim Hanson, and I'm going to be talking about ways in which we utilize diagnostics to take care of patients. And I thought probably the best way to do this was to tell you about a patient that we took care of at our medical center last week when I was on the Transplant Infectious Diseases Service. So this was a 62-year-old man. He'd received a liver transplant about 2 weeks ago, and had really been doing well in the hospital recovering from the surgery when he had the sudden onset of a new fever and very low blood pressure. So that's why our infectious diseases service was called to come evaluate him and think about what could be going on. When we talked to the man, he really had no localizing complaints or concerns. He just felt a little dizzy because his blood pressure was so low, and he recognized that he probably had a high fever. Because he was pretty unstable, we recommended that he be transferred to the intensive care unit, and there we kind of started our diagnostic workup. The first thing to do was to stabilize him. We gave him IV fluids. We gave him some medicines to support his blood pressure. But the next thing was to try to figure out what was going on, and it looked for all the world like an infectious process. So to do that, the first thing we did was draw cultures of his blood and cultures of his urine, and then start broad-spectrum antibiotics. And by broad-spectrum antibiotics, I mean we often pick multiple drugs to cover the organisms that we think are most likely in a particular patient in a particular setting. And because we still don't know what's going on, we're waiting for a diagnostic test, we're taking our best guess at what this patient could have. We call this empiric antibiotic use. So we got our antibiotics started and went back to see the patient the next day, and unfortunately he still wasn't doing that much better. And then we got a call that next day, later in the afternoon, from the clinical laboratory to say, well, we've got his blood cultures now. We've identified that the blood culture is growing a bacteria. We've taken an aliquot of the blood that was in the blood culture bottle and stained it, and we can tell you that it looks like a gram-negative bacteria. And because of the way it looked under the microscope, we applied a rapid diagnostic test. It's a molecular-based test that looks for the most common causes of bloodstream infections in hospitalized patients. It's a commercially available test. It's FDA approved. There are multiple options on the market for this. And in about an hour, they could screen the patient's blood and say, yes, we've detected a bacteria there, we can put a name on it, and we can also tell you that it has some important resistance mechanisms. So in this case, the organism that was identified was Klebsiella pneumonia. It fit with the gram stain, and it did have a resistance gene called KPC gene, and that stands for Klebsiella pneumonia carbapenemase. The carbapenemase is an enzyme that is able to degrade or break down our most important group of antibiotics, such that those drugs are no longer effective. So in about a day, we knew, well, we started that empiric antibiotic, and guess what? We picked a drug that would not be expected to be effective for this patient because of the resistance mechanism. We took that KPC information, the carbapenemase information, to move away from a carbapenem drug. We changed his antibiotics immediately. And when we saw the name of the organism, we had a pretty good guess of where this might be coming from. In a liver transplant patient, this organism likely was a complication potentially of the surgery, and having been in the hospital, we ordered a CT scan of his abdomen, and lo and behold, the answer was there. Certainly a complicated scan. I don't know if I have a pointer, but kind of in the middle next to the black area is a large fluid collection that shouldn't be there. That's an abscess or a collection of infection in the abdomen. We called our interventional radiologist to quickly come and drain that collection. What we also did, though, was start hospital infection control practices. Because this bacteria is resistant or predicted to be resistant to multiple antibiotics, we recommend that any physician or clinician, nurse going into the room to care for the patient put on a gown and gloves to try to prevent getting the infection on their skin and potentially transmitting it to the patient next door. Although it might not be harmful for a healthcare provider, it certainly could be harmful for the kidney transplant or heart transplant patient who's next door to the patient and cared for by the same group of physicians and nurses. And lastly, to notify our infection control or infection preventionists to let them know that we've identified a patient with a multi-drug resistant organism. So that's what happened on the clinical side. Luckily, with draining the abscess and changing the antibiotics, the patient quickly stabilized. But I want to turn now to what we do in the clinical laboratory to get more information about this bacteria and really better inform our infection control practices as well as potentially the public health. So our charge on the lab side now was to take that blood culture and try to get the organism out of the blood, grow it on a plate, which is shown here up on the left hand of the slide, and really definitively identify it. Say, yes, indeed, this is Klebsiella pneumonia. And in addition, we're going to test that bacteria in the presence of multiple drugs to confirm that it is or is not resistant to the carbapenem class, but also other antibiotics. And that was done. We grew the same organism from the blood and from the abscess and did our full panel of antibiotic susceptibility testing and showed, as was predicted, the organism resistant to multiple classes of drugs except for one. And the CDC recommends when we identify these germs, especially in this kind of family of bacteria, the Enterobacteriaceae that are resistant to the carbapenems, we do some extra work to really confirm what that resistance mechanism is because it's important for infection control and public health surveillance and tracking. There's a variety of different ways in the lab we can confirm the presence of the carbapenemase. I told you we had that rapid test that was a genetic test. We found the gene. There's also other things we can do. In our lab, when we have an actual bacteria isolate and we're suspicious for carbapenemase production, we grow that organism in the presence of the drug and actually look for hydrolysis of the drug. When the drug is broken down, the pH of that media changes, and we can detect that with a color indicator for pH. So what does that mean for our hospital? If we detect carbapenemase detection either with a molecular test, like I mentioned, the rapid test, or these more phenotypic growth-based tests, we do a number of things. And one is we make sure we've got our infection control practices in place. We're wearing gloves, we're wearing gowns, we have really diligent hand hygiene, we're washing our hands, which we should always do. But we also might start an investigation locally on that ward to see if the organism has spread from our index patient to other patients next door. And we do that with actually rectal swabs. We swab the skin around the rectum. That's a place where these bacteria, if a patient has been exposed or acquired, may harbor the bacteria locally, either in the gut or on the skin. And we take that swab, and in our lab, we do kind of a laboratory-based test looking for all the genes that could potentially encode the carbapenemase, not just the KPC, which was on the rapid test. That's the most common gene. If we see that other patients have potentially picked up the germ, having been in the hospital, we might do some cohorting. We keep those patients near one another. We cohort the staff that takes care of them, the doctors, the nurses, and really try to keep it, walled off in a way to prevent spread to others in the health system. Our state health department also tracks this as well, and so we would report to them and mention and tell them that we've had cases locally in our hospital. If that screening test is negative, it's easier. There's other ways a bacteria can become resistant to the carbapenems. It's not always a carbapenemase enzyme production, and in that case, it's more standard hospital infection control practices and not the augmented screening. So I like this case because I think it gives you guys a sense of not only how we use diagnostics to manage an individual patient, but also how it affects our hospital infection control and reporting to the state. And I think it's a nice example, too, that in infectious diseases, and this was mentioned by a previous speaker, it's not just one test that we're going to hang our hat on. It's usually a combination of tests that we do and take it in the context of an individual patient to make treatment decisions. This is also a nice example, too, because we've got the very old tests, culture, gram stain. Gram stain, I think, was invented in the 1800s. We're still using it. But we're also using very, new high-tech molecular methods to look at DNA, to look at genes, and get rapid answers. I don't have time to talk about number 4, number 5, but diagnostics and clinical practice potentially are also useful for enrollment in antimicrobial clinical trials. So you could imagine there's a new drug that's been developed for these really multi-drug resistant bacteria, and a rapid test would allow us to say, hey, this is a patient who might qualify for that study and could potentially be enrolled to help study some of these new drugs which are desperately needed. There is a general sense, though, both from an infectious diseases physician perspective, but also from the laboratory perspective, that even our best tests sometimes are underutilized by other physicians and laboratories. And so I want to talk about briefly just potentially what some of the barriers are to uptake of current diagnostic tests or bringing in new and improved diagnostic tests into clinical care. Let's start from the laboratory perspective. Unfortunately, one of the first things we think about when we're thinking about bringing a new test in our lab is how much is it going to cost, and will I be reimbursed at a level that covers the cost of testing? Unfortunately, reimbursement for diagnostic tests in infectious diseases have gradually come down over time, and there may be tests for which we can't recoup the costs to run the assay. When that's the case, we ask another question. Well, okay, so it might not be financially beneficial to the clinical lab, but does it make a difference for patients? That's why we're all here. That's the most important thing. If there's a test that has been shown in studies and there's good data that it either improves mortality or it gets patients out of the hospital sooner, it allows us to use less or more targeted antibiotics. If the savings are downstream to the health system, we still might bring it in-house. But one of our frustrations is there's really very limited clinical data on the utility and impact that diagnostics can have for patients at those levels. We also have to ask, how difficult is the test? Does it already exist? Is it something that's commercially available and FDA approved that I can bring in my lab? Is it something I need to develop myself? Do I have the expertise and the staffing to do that? And lastly, how quickly do I need to turn the test around to give the physician the result? Do they need the results in 24 hours to make it useful? Is it something that could come back in a week? Where does the testing need to be performed? Near the patient, at the core laboratory, at a reference laboratory? Those are all considerations when we're thinking about bringing in new tests. From the doctor's side, it's the exact same considerations. It's just a little bit of a different perspective, right? So when I think about ordering a test for a specific patient, I always think about, well, how much is it going to cost the patient, and will their insurance, if they have it, cover it? It's hard to find that information sometimes. Again, getting to utility, will having the results of this test improve the outcomes for my patient? Will it inform my medical decision-making in a way that's expected to really benefit this individual? Again, we need more studies to show that. More and more, our infectious diseases diagnostics are becoming more complex, both technically to perform in the laboratory, but also for clinical clinicians, nurses, and others to interpret the results. So I think sometimes physicians are reluctant to order a test because they don't know how to interpret what it means or what to do with the results. And lastly is test availability. Does a test exist? We recently polled physicians, many of whom are infectious diseases physicians, and asked, what are your major unmet diagnostic needs for infectious diseases? What are the organisms or syndromes that we really need improved and new tests for? And it was interesting that the top 3 organisms they listed, we have excellent commercially available diagnostic tests for. So it showed us either, number one, they don't know that the test exists and how useful and robust and accurate they are, or 2, their lab doesn't offer it for the reasons on the left-hand portion of the slide. Or 3, their lab does offer it, but they can't get the results back in a meaningful time frame, so they might as well do their empiric antibiotic treatment or antiviral treatment, and by the time they get the answer, often the cat's out of the bag and the patient's either gotten better or has not. But there's problems with empiric antibiotic use, and that does drive resistance, unnecessary antibiotics potentially in certain situations. So I think there are some potential solutions to these barriers. First is to ensure appropriate reimbursement for the clinical laboratory, at least, to perform these tests, and that is through CMS. To promote education for our clinicians, to get out on the street and let them know we've got these tests, how they performed, and how they should be used in clinical practice. And also, I think we need to continue to encourage the government to fund diagnostics research at all levels. So we need studies that really prove outcomes that testing can make a difference and improve care of these patients, that it does improve limited resource utilization and antibiotic utilization. We also need to prioritize the development of new technologies, as Dr. Bell has mentioned, with sequencing, an extremely powerful tool. And lastly, incentives for drug companies and academic laboratories to develop new tests for rare diseases, which often there are no tests that exist for many of these pathogens. So to summarize then, I tried to show the power of diagnostics, both the way that we use these tests to take care of patients, but also how they can be used to inform antibiotic stewardship and the public health and infection control. And in the future, we need to continue to innovate. I think if we could have improved on this case that I mentioned with our liver transplant patient would be to have a test that we could apply directly to the blood to detect that organism and its resistance mechanisms without having to grow it in culture and wait that additional 24 hours. Downstream, we still want to have the organism in hand to kind of confirm our rapid results, but time is critical for many of these infectious diseases, and we need to be able to do this quickly and near the patient. So with that, I'll conclude my remarks, and I look forward to the discussion. Thanks.